Hello, hi everyone. The topic of today's lecture is natural and artificial occlusion. By artificial occlusion, we'll be talking about occlusion in complete dentures. Moving on to learning outcomes, you're expected to distinguish the difference between the natural as well as artificial occlusion. You should be able to describe the requirement for complete denture occlusions. You should also know about the theories of occlusion as well as you should be able to declare the various type of posterior tooth forms. These two things have already been covered in previous lecture, that is selection of artificial teeth. You should be able to describe the concept of occlusion, what occlusion is. You should be able to describe the various factors affecting balanced occlusion, which we'll be talking about in detail. And you should also know about the monoplane occlusion as well as the lingualized occlusal schemes. Coming to the introduction. Now, what is occlusion? Occlusion is a static relationship between the incising or masticating surfaces of maxillary mandibular teeth or the tooth analogues, that is artificial teeth. So, occlusion is basically the relationship between the occlusal surfaces or occluding surfaces of the teeth. Prior to the selection element of the artificial teeth, the type of occlusal scheme is planned. That is whether we are going to go for a balanced occlusion or a lingualized occlusion or a monoplane occlusion, or whether we are not going to use balanced occlusion at all. It is important to understand the differences in the occlusion between natural teeth and the complete denture teeth. After all, they are quite different from each other. Now let us take a look at the differences between the natural and artificial occlusion. As we all know, natural teeth are retained in the periodontal ligament, which is anchored in the bone of the maxilla and the mandible. So these are the natural teeth. The green area is the PDL, periodontal ligament, which encompasses the root of the teeth and which are anchored to the alveolar sockets. Now, as we can see here, the teeth are independent of each other and they move independently to the masticating and the occluding forces. If there is any malocclusion, it affects independently that teeth only and does not affect the other teeth per se. Non-vertical forces such as lateral forces in the mesodistal or buccolingual direction, they are usually tolerated well and they are tolerated by the teeth in question. They do not affect all the other teeth in the arch. Bilateral balanced occlusions are rare in the natural dentition since it is not a natural thing and it is a man-made or the type of occlusion which is specifically created to be designed in complete dentures for the sake of stability and retention of the complete dentures. So natural dentition does not have balanced occlusion. It is governed by different factors such as we can see canine guided occlusion, we see group function occlusion, we see maximum intercuspation. Also, because of the PDL ligament which contains various receptors, namely like mechanoreceptors, proprioceptors, the teeth have excellent tactile sensibility. Whereas when you look at denture teeth, that is artificial teeth, denture teeth are anchored to mobile bases on the mucosa. So this is a denture where this is the basal seat of the denture and the teeth are added to the basal seat or fixed to the basal seat. They do not move independently. They are not anchored into the ulnar socket like the natural teeth. So therefore the teeth move as a unit and malocclusion will affect the stability of the entire denture. Non-vertical forces will affect all the teeth and may result in trauma to the underlying soft tissue. Incising affects all the teeth that are attached to the base. Bilateral balanced occlusion is often hence required for the stability of complete dentures. There is no or decreased tactile sensibility, as tactile sensibility or sensitivity is only confined to the sensory feedback from the mucosa. Now, looking at some relevant terms. So once again, we come back to centric relationship. Countless times we have described the definition of centric relationship. I'm sure most of you must be knowing this by now. Centric relation is a maxillomandibular relationship independent of the contact of the tooth in which the condyles articulate in the anterior-superior position against the posterior slopes of the articular eminence. So this is the articular eminence, this is the anterior slope, this is the posterior slope, and the condyles are in the anterior-superior position. In this position, the mandible is restricted to a purely rotatory movement. That is, the mandible does not display any sliding movement or any Bennett side shift. It purely rotates like a hinge around a terminal hinge axis. that is a true axis of the mandibular or the condylar rotation. The patient can make vertical lateral protrusive movements from this position, and it is a useful and clinically repeatable position, that is centric relationship. As I mentioned, it is independent of tooth contact, it is purely rotatory, and it is anatomically determined by the articular eminence, the glenoid fossa, the articular disc, and the head of the condyle, as well as the elasticity of the ligaments of the temporomandibular joint. So, next, coming to the requirements of a complete denture occlusion. The cutting and shearing efficiency of the incisal occlusal surfaces with sluice face for escape of the food. There should be minimal area of contact to reduce the forces on the residual alveolar ridges during mastication. There should be a favorable tooth to ridge crest position for the functional liver balance. That is, tooth should be arranged on the center of the ridge, following along a line drawn along the center of the ridge. There should be reduced posterior cuspal height to control the horizontal forces. That is, the cuspal inclines should be shallow. There should be reduced buccolingual width of the posterior teeth so as to decrease the forces transmitted to the underlying residual ridges. Also, they should have a surface to direct the forces in a vertical direction. Occlusal forces should be directed towards the anterior posterior center of the ridge. Also, the occlusal plane should be parallel to the mean foundation plane. They should allow the setting of the denture bases without interference or locking of the cusp. No anterior teeth contact should be there except during protrusion or retrusion. That is, during maximum intercuspation or during centric occlusion, the anterior teeth should have sufficient overjet to prevent the contact between the anterior teeth. The stability of the occlusion in centric, there should be stability of occlusion in centric and eccentric relationship. This can be achieved only if we are planning balanced occlusion in complete denture. Other terms like maximum intercuspation. Maximum intercuspation, the complete intercuspation of the opposing teeth independent of the condylar position. Sometimes referred to as the best fit of the teeth regardless of the condylar position. This is usually seen in the natural dentition. In the complete denture, we make sure that the centric relation and the centric occlusion coincide. So what is centric occlusion? It is the occlusion of the opposing teeth when the mandible is in the centric relationship. Now, other terms like Christensen's phenomenon. What is Christensen's phenomenon? It is the creation of space between the posterior teeth bilaterally during protrusion or during laterotrusive excursions. That is, the anterior teeth will prevent the contact of the posterior teeth during protrusion, and the canine will prevent the contact of the posterior teeth during the lateral excursion. This is so that the anterior teeth protect the posterior teeth during excursive movements, and during centric relationship or maximum intercuspation, the posterior teeth protect the anterior teeth from coming into contact. As I mentioned again, this is only confined in the natural dentition. Now coming to balanced occlusion. Balanced occlusion per se by definition is defined as a bilateral, that is both right and left, simultaneous anterior and posterior contact of the occlusal surface of the teeth in centric and eccentric positions. It is developed to lessen or limit the tipping or the rotating of the denture bases in relation to the supporting structures. Balanced occlusion is uniquely in complete dentures, and as I mentioned, is not a part of the natural teeth. So what are the objectives of balanced occlusion? First, the primary objective is to improve the stability of the denture during function, that is mastication, chewing, gnawing, etc. It should improve the stability and retention of the denture during parafunctional movements. It should reduce the resorption of the residual ridges, as we are aiming to limit the forces on the residual ridges. Thereby, we intend to reduce the resorption of the residual alveolar ridges and to reduce the trauma from the occlusal forces on the oral tissues, and that is mucosa and the residual ridges, and also to improve the comfort for the patient by ensuring that we allow all the above objectives. Now coming to the factors that affect the balanced occlusion, there are five factors, namely the condylar guidance, the incisal guidance, the occlusal plane, the compensating curves, and the cuspal inclination. These five factors were originally described by Hanau as Hanau's Quint. Now coming to condylar guidance. So condylar guidance is a mandibular guidance generated by the condyle and the articular disc traversing the contour of the glenoid fossa. So this is the glenoid fossa, and the movement of the condyle against the incline of the glenoid fossa is termed as the condylar guidance. Condylar guidance is due to the path followed by the condyle in the temporomandibular joint capsule. So this is the mandibular guidance. Also, condylar guidance is known as horizontal guidance. This guidance is generated by the condyles traversing the contours of the glenoid fossa. It is then duplicated in the articulator. The extent of the duplication depends upon the ability of the articulator, whether it is a non-adjustable articulator, a semi-adjustable articulator, or a fully adjustable articulator like class 4A and B articulators. Now, the protrusive condylar guidance is obtained when we obtain protrusive records from the patient, and lateral condylar guidance are obtained by using Hanau's formula, which was described in the previous lecture, or by using lateral records in articulators that accept the lateral records. So, when the condylar guidance is ideal, that is, we aim to keep the condylar guidance minimal so that during protrusion, the posterior disclusion between the occluding surfaces of the upper and lower dentures remains minimal. If the condylar guidance is steep, it will create a excessive separation of the occluding surface of the posterior teeth during protrusion and retrusion, which we do not want in complete dentures. Next up is the incisal guidance. Incisal guidance is the angle formed between the horizontal plane of the occlusion, that is, this is the horizontal plane, and the line drawn in the sagittal plane between the incisal edges of the maxillary and the mandibular teeth in maximum intercuspation. So this is the incisal guidance, that is between the occlusal plane and between the occluding surfaces of the maxillary and mandibular anterior teeth. So this is our incisal guidance. Now, if this angle is steep, it will require steep cuspal incline, steep occlusal plane, and steep compensative curves to obtain the occlusal balance. So, usually in class 2 type of dentition, or when we are unable to arrange the teeth in any other occlusal scheme other than class 2, the incisal guidance is very steep. In that case, we have to increase the horizontal condylar guidance. We have to increase the cuspal inclines by selecting anatomic teeth which have a 33-degree angulation of the cuspal inclines instead of semi-anatomic or non-anatomic teeth. We will also have to make the occlusal plane more steep instead of parallel to the residual ridges. We will need to use steep compensating curves like the curve of Spee, curve of Wilson, curve of Monsoon, Pleasure's curve, etc. All in an effort to create a balanced occlusion with when the incisal guidance is steep. Whereas when the incisal guidance is shallow, like in this case where the overjet is we have a sufficient overjet of the maxillary and mandibular anterior teeth, in that case we can have a shallow condylar guidance. We can use a steep less steeper occlusal plane. We can use semi anatomic teeth which have a 20-degree cuspal incline instead of the anatomic teeth. So now coming to the third factor that affects the balance occlusion is the orientation of the occlusal plane. Now, as we know, occlusal plane is the parallel contact between the upper and lower occluding rims in complete denture. Usually, occlusal plane is defined or determined by the parallelism with the alatragal line in the lateral view, and in the frontal view parallelism with the interpupillary line. And in the mandibular complete denture, the occlusal plane should be parallel or extend up to the two-thirds of the retromolar pad. Usually the aim is to provide occlusal plane which is midway between the occluding ridges, that is between the edentulous maxillary and mandibular ridges. It is oriented in the same relationship as when the natural teeth existed. Hence, there is not much scope to maneuver the occlusal plane. But yes, as I mentioned, if the incisal or condylar guidance is very steep, the occlusal plane instead of horizontal can be made slightly steeper. So next, compensating, coming to the compensating curves. Compensating curves are the anterior, posterior, and lateral curvatures in the alignment of the occluding surfaces and incisal edges of the artificial teeth that are used to develop balanced occlusion. So what are these compensating curves? There are basically two categories of compensating curve: anterior posterior curves and posterior mediolateral curve. Anteroposterior compensating curves like the curve of Spee, they run in the AP direction, that is anteroposterior direction, and help in obtaining a protrusive balance. Whereas the mediolateral compensating curves, they run in a lateral direction and they are helpful in obtaining the balance in the laterotrusive movements. So let us come to the curve of Spee, which is an anterior compensating curve. So curve of Spee is located in a AP direction, that is anteroposterior direction, and it is a curve that begins with the cusp of the mandibular canine and following the buccal cusp of the premolars and the molar teeth, continuing through the anterior border of the ramus of the mandible, ending with the anteriormost portion of the mandibular condyle. So basically, curve of Spee is a curve that follows the tip or the incisal edges of the occluding surface of the mandibular teeth. So basically, it is like the monsoon curve where the teeth are occluding against the surface of a sphere which is 8 inches in diameter and the center at the glabella. This was first described by Graf Spee in 1890. So this compensating curve will help us in the balance of the denture in the protrusive movements of the mandible. Next up is the curve of Wilson. This is a mediolateral curve. This curve is convex downwards, that is towards the mandible. The curve appears like a convex profile. This was given by Wilson in 1911, and this is again useful in the arrangement of teeth in the balanced occlusion. It is used for the arrangement of the molars. The lingual molars or the lower molars are tipped lingually, whereas the upper molars are tipped buccally in order to get balance during laterotrusive movements. Next is the anti-monsoon curve or the reverse curve. This is a curve which is concave in a mediolateral direction. That is, curve of Wilson was convex in a mediolateral direction, and this reverse curve or anti-monsoon curve is concave upwards. That is, this is usually used to arrange the first premolar. That is, as you know, in a glass plate relationship, the maxillary first premolar, only the buccal cusp should touch the glass plate. This is because of the reverse curve of the anti-monsoon curve. Next, coming to the curve of monsoon. Curve of monsoon is also a mediolateral curve. This is a curve of occlusion in which each cusp and incisal edge conform to a segment of a sphere 8 inches in diameter with its center at the glabella. This was described by George Monsoon. This curve is a three-dimensional and is a combination of the curve of Spee and curve of Wilson. So all these curves conform to a sphere which is 8 inches in diameter with the center at the glabella. So here we can see this is the mandible, and the occluding surface of the mandibular teeth conform to a sphere which is 8 inches in diameter and with its center at the glabella. So this is a mediolateral curve, that is the curve of monsoon, and if you see it in anteroposterior plane, it is called as a curve of Wilson. Next up is the pleasures curve. This curve is usually associated with reversal of the occlusal plane in the premolar, first molar and the second molar teeth, whereby the occlusal surface of the mandibular teeth slope facially. So here we can see occlusal surface of the mandibular teeth are sloping facially. This we usually see, or this type of pleasure curve is given when we use monoplane teeth or 0-degree teeth. There are no cuspal inclines, and in old dentures, patients who have been wearing dentures for 10 years, 15 years, there is attrition or wear out of the occlusal surfaces, and we get to see what is termed as the pleasures curve. So in this type of curvature, the premolars are, the maxillary premolars are tipped buccally. That is the first premolars and the second premolars. The mandibular first molar is kept, has a flat occlusal plane, that is, it is neither tipped buccally or lingually, whereas the mandibular second molar has a sloping occlusal surface which is sloping facially. So these three are a combination of the pleasures curve. So this is the combination, this pleasures curve is a combination of the curve of Wilson, the reverse or curve or the anti-monsoon curve, and the first molar is set at a flat occlusal plane. So curve of pleasures curve is the combination of curve of monsoon and the anti-monsoon curve. It is used for arranging, as I mentioned, non-anatomic or 0 degree teeth in a balanced occlusion. Now coming to the last factor, that is the cuspal inclination. Cuspal inclination is the angle made by the average slope of the cusp with the cuspal plane measured mesiodistally and buccolingually, and it is also called as the cuspal angle. This has an effect on the occlusal plane and the compensating curve. They are interrelated, that is the slope of the occlusal plane, the compensating curve, and the cuspal incline. They are all interrelated to each other. The closer a tooth is located to the condylar guidance, the more influence the guidance has on the cuspal inclination. In anatomic teeth, it is preferable to eliminate the mesodistal cuspal inclines as they only have and as then only buccolingual inclines are needed to be considered for balanced arrangement of the. So this is a Hanau's Quint, which I mentioned earlier, and all the five factors such as the condylar guidance, the incisal guidance, the plane of occlusion, the cuspal inclination, and the compensating curve are determining factors in the balanced occlusion. Now coming to the monoplane occlusion. After balanced occlusion, next up is a monoplane occlusion. This is an occlusal arrangement wherein the posterior teeth have masticatory surfaces that lack any cuspal height. That is, the posterior teeth do not have any cuspal inclines or the cuspal height, such as you see in the anatomic teeth or semi-anatomic teeth. Basically, we have a flat occlusal scheme with only sluice ways for the chewing and mastication. This is an occlusal arrangement in which we use non-anatomic teeth or monoplane teeth or 0 degree teeth. This is based on the philosophy that by eliminating the cuspal incline, the lateral forces on the denture will be reduced, thereby enhancing the stability of the denture, especially in poor or extremely resorbed residual alveolar ridges where you don't have any vertical walls of the ridge to prevent the lateral movement of the dentures to begin with. So this is not an ideal occlusal scheme, but when we, in certain situations, we prefer to use monoplane occlusion. So the anteteeth are arranged with an overjet of 2 mm and no overbite. So there should be an overjet of 2 mm between the anterior teeth, and there is no overbite, as the overbite will cause the disclusion of the posterior teeth and will increase the instability of the denture. So how do you bring about balanced occlusion in a monoplane occlusal scheme? This can usually be achieved by creating a ramp or slope just distal to the mandibular second molar. So when the patient does protrusive mandibular movements, in that case, when the disclusion of the posterior teeth occur, this balancing ram will keep contact with the upper denture base or the upper second molar and give a 3 point contact, that is two balancing rams on the posterior, anterior contact with the anterior teeth during protrusive movement. This will create a sort of balance occlusion or the balanced relationship of the upper and lower dentures in relation to the monoplane teeth. The another way of improving balanced occlusion in a monoplane occlusal scheme is to reduce the number of the teeth. That is, by eliminating the second molar or by reducing the anteroposterior occlusal table, we can improve the balance or the balancing arrangement in a monoplane occlusion. So what are the advantages of monoplane occlusal scheme? First of all, it is very easy to arrange the teeth in a monoplane occlusal scheme. We do not require a semi-adjustable articulator or fully adjustable articulator. We can use a simple hinge articulator such as a class 1 or class 2 articulator. It is easier for the occlusal team to achieve, especially in the following conditions, such as if the patient has poor neuromuscular control, patient has malocclusion like a class 3 or class 2 ridge relationship, when there is excessive residual ridge resorption. In these cases, is it easier to achieve a centric relationship in a monoplane occlusal scheme. What are the disadvantages of this monoplane occlusal scheme? First of all, it is less aesthetic, as because there are no cuspal inclines, a flat occlusal scheme. There is less chewing efficiency because there is no cuspal height, there is no sharp cusp to actually share the food or help in the grinding. So patient has to put a lot of effort in grinding or mashing the food, which is already difficult because of the poor residual ridges. Unstable denture in patient with a steep condylar guidance. In patient that may have a steep condylar guidance, or the occlusion of the teeth is very close to the condylar guidance or the TMG of the patient. In such cases, like class 2 relationship, it is difficult to have a stable denture in such situations. Next, coming to the lingualized occlusion. Lingualized occlusion can be defined as a form of denture occlusion where the maxillary lingual cusps articulate with the mandibular central occlusal surface. That is, they articulate with the central fossa of the occlusal surfaces in a centric, working and non-working mandibular position. So these are the maxillary teeth with a prominent palatal cusp, and the mandibular teeth that generally have shallow cuspal inclines. And in centric relation on or centric occlusion, only the palatal cusp of the maxillary teeth articulates with the central fossa of the mandibular posterior teeth. This, in a way, creates a balancing occlusion in laterotrusive contacts. We can see when the patient does left and right laterotrusive movements of the mandible, always the palatal cusp of the maxillary denture teeth are in contact with the occlusal surface of the mandibular posterior teeth, thereby creating a sort of balanced occlusion. Indications of lingualized occlusion is when there is high aesthetic demand, when there is severe mandibular ridge resorption, when there are displaceable supporting tissues like thick mucosal biotype, flabby ridges, or traumatic ridges, when there is malocclusion, that is, we find class 3 or class 2 relationship. Most of the indications are similar to monoplane occlusion. A patient with previous successful denture with a lingualized occlusion in even today, we see many of the European countries, lingualized occlusion is followed by many doctors and denture technicians for the arrangement of the artificial denture teeth occlusal scheme. Advantages are good aesthetic because it is better than the monoplane occlusion. There is freedom of the non-anatomic teeth. There is a potential for bilateral balance. As I mentioned, always the palatal cusp of the maxillary posteriors is in contact with the occlusal surface of the mandibular posteriors. The contact of the palatal cusp of the maxillary teeth ensures that the forces are transferred in a vertical direction to the mandibular areolar ridges. There is minimum tipping forces because of the centralization of the vertical forces, and because the palatal we are using anatomic teeth in the maxillary ridge, it is easier for the chewing and for the sharing of the forces, basically a mortar and pestle effect. So next, coming to the summary, the occlusal scheme selected should satisfy the aesthetic and functional needs of the patient. Anatomic teeth show slightly better chewing efficiency than the non-anatomic teeth because they have cuspal inclines and the sharp cusp. The concept of bilateral balanced occlusion and its necessity has been debated for many years. Due to the real effect or resiliency-like effect of the mucosa, which was first described by Hanau, who stated that the mucosa overlying the residual ridges is mainly 80% of water. So when the upper and lower denture come in contact during the mastication, the occlusal forces cause the compression of the mucosa of the residual ridges, thereby causing settling of the denture. So this is termed as a resiliency-like effect. So he questioned the actual necessity for the balanced occlusion to be incorporated in complete dentures so that there is contact in the eccentric as well as centric movements. That is why one of the reasons why balanced occlusion is yet to be accepted by general dental practitioners. Although creating balanced occlusion is very difficult, it requires a lot of expertise and lot of experience, and you have to have a phase bone transfer, orientation jaw relationship, and a semi-adjustable articulator in order to create balanced occlusion. The basic requirement of a occlusal scheme is certainly to provide a maximum intercuspal contacts of all the posterior teeth in centric relationship along with no contact of the anterior teeth. There should be sufficient overjet of the anterior teeth with minimum overbite so that the teeth or the dentures remain stable during the occlusion. So that brings us to the end of this lecture.